Congestive heart failure, CHF, and chronic obstructive pulmonary disease, COPD, are two distinct but oftentimes coexisting chronic conditions affecting millions worldwide. CHF is primarily a cardiac disorder characterized by the heart's inability to pump blood effectively, leading to symptoms like breathlessness, fatigue, and fluid retention, particularly in the legs and lungs. On the other hand, COPD is a progressive lung disease marked by persistent respiratory symptoms such as chronic cough, wheezing, and shortness of breath due to airway and/or alveolar abnormalities. Treatment for both conditions may include lifestyle changes, medication, and in severe cases, surgery or specialized therapies to manage symptoms and slow disease progression. Risk factors for CHF include high blood pressure, coronary artery disease, and diabetes, while COPD largely stems from long-term exposure to lung irritants, especially cigarette smoke. Here's a detailed look at the intricate aspects of CHF and COPD, exploring their impacts and interrelations in affected individuals. Affected organ system, cardiovascular versus respiratory. When discerning between congestive heart failure, CHF, and chronic obstructive pulmonary disease, COPD, the primary point of divergence lies in the affected organ system, cardiovascular for CHF and respiratory for COPD. CHF generally compromises the heart's ability to pump blood effectively, leading to symptoms such as dyspnea, fatigue, reduced exercise tolerance, and fluid retention manifesting as peripheral edema and pulmonary congestion. Conversely, COPD, a progressive respiratory disorder, primarily causes airflow limitation and obstructive symptoms including chronic cough, sputum production, and shortness of breath. Clinical evaluation often involves imaging such as echocardiography for CHF and spirometry for COPD, alongside careful symptom assessment to distinguish the primary etiology, cardiac or pulmonary. Understanding these differences is crucial for accurate diagnosis and effective management, as treatment strategies differ significantly between the two conditions. Characteristic sounds, crackles versus wheezes. Congestive heart failure, CHF, and chronic obstructive pulmonary disease, COPD, often coexist, making diagnosis challenging due to overlapping symptoms. Auscultation reveals distinct sounds that can aid in differential diagnosis. In CHF, crackles or rales are typically heard on lung auscultation, especially at the lung bases, caused by fluid accumulation or pulmonary edema. These fine, high-pitched sounds are elicited during the end of inspiration. On the other hand, COPD is characterized by wheezes, high-pitched sounds produced by the narrowing of bronchial airways, heard predominantly on expiration. Recognizing these acoustic signatures is critical for clinicians to implement appropriate treatments and manage the underlying conditions effectively. Primary dysfunction, pump failure versus airflow obstruction. In differentiating between congestive heart failure, CHF, and chronic obstructive pulmonary disease, COPD, the primary dysfunction under the lens is the battle of pump failure versus airflow obstruction. With CHF, the heart's ability to pump blood effectively is compromised, leading to a backup of fluid in the lungs, extremities, and other tissues. This manifests as breathlessness, fatigue, and edema. In contrast, COPD is characterized by a persistent blockage of airflow due to lung tissue damage and airway inflammation, resulting in breathing difficulties, cough, and mucus production. Understanding the nuance of these symptoms is critical for clinicians to direct the appropriate pathophysiological treatment, whether it be improving cardiac output or enhancing respiratory function. Characteristic sounds, crackles versus wheezes. Characterizing lung sounds is crucial in differentiating congestive heart failure, CHF, from chronic obstructive pulmonary disease, COPD. In CF, the lungs typically produce crackles, which are fine or coarse bubbling sounds created by fluid accumulation within the air sacs due to the heart's inability to pump effectively. Crackles emerge during the end of inspiration and are commonly heard at the lung bases. In contrast, COPD is hallmarked by wheezes, which are high-pitched musical sounds that occur during expiration, particularly caused by narrowing of the airways from inflammation, mucus buildup, or bronchospasm. Identifying these distinctive sounds through a stethoscope plays a pivotal role in directing further diagnostic investigations and initiating appropriate treatment strategies. Exercise tolerance, decreased with activity versus decreased with exertion or at rest. Congestive heart failure, CHF, and chronic obstructive pulmonary disease, COPD, can both lead to reduced exercise tolerance, but it's crucial to distinguish how they manifest. In CHF, exercise tolerance typically decreases with activity due to the heart's inability to meet the body's increased demand for oxygenated blood. Patients may experience fatigue or shortness of breath during physical tasks as the heart struggles to pump efficiently. On the other hand, COPD patients suffer primarily from lung dysfunction, which leads to breathlessness with exertion or even at rest. This impairment is due to obstructed airflow and decreased lung capacity, making it difficult to maintain adequate oxygen levels. Properly identifying these nuances is essential for effective management and therapy for these two distinct conditions.